Hello everyone, this is Professor Yamini Bhushan Tripathi, former Dean Faculty of Ayurveda, Institute of Medical Sciences, and I am interacting with all of you on a 12-week certificate course in palliative care with integrative approach. And now I am going to talk about a very unique topic called geriatrics overlapping non-communicable diseases. In the earlier slide, I think some of the lectures I have already told you that the 60% of the palliative care seekers are old age people. They are the elderly people, and they are suffering with the chronic diseases which is not curable. So if a patient comes to you, he has two problems. He has a geriatric problem and he has a disease problem. And in modern medicine, geriatrics is not considered as a disease. It is a time of life. But in Ayurveda, they say jara vyadhi. So jara vyadhi means the treatment of jara should also be there. And Maharshi Charak has given a dedicated chapter for management of jara vyadhi, that is called the Rasayan and Vajikara. So it means jara will come to everybody. Nobody can be escaped. Before death, he will get old, and with getting the aging, he will get sense prone to onset of many diseases, maybe infectious disease, maybe non-infectious disease, but because of the aging, his immunity will be compromised and he is more susceptible to a different kind of disease. But in the modern medicine, there is a different department of geriatrics. They deal only with the old people, their problems, and they don't talk about palliative care. But as a trainee, you have to understand what is geriatrics and what is palliative care. So, assessment of geriatrics has a very strong tool given by the geriatric physician, but you should know a little bit about it so that you can link your patient with a specialist of geriatrics when needed. You can only do that when you know it. That's why this class is focused to make you understand what is geriatrics. So, chronological aging and obesity, most of the time, and the symptoms at biochemical level of obesity and aging are same. That is what is the common thing? Systemic inflammation. In the body, the inflammatory cytokines are at high level. In Ayurveda, we say Vata dosha. Vata is high. In the aging, Vata is high. In the obesity, inflammatory obesity, Vata is high. If Vata is high, means inflammatory cytokines are high, means the vascular system is getting compromised day by day. You will end with the hardening of the vessels and the softness of the bone because of the Vata. So two things happen in your old age. Your hard tissues like bone become soft, like it goes to osteoporosis and something. And soft tissues like blood vessels, muscles, they become hardened because of calcium deposition, because of other things. So this is a common man perception, I am telling you. In Ayurveda, fat accumulation in old age can be explained by concept of doshas, primarily kapha dosha, responsible for structural lubrication and stability in the body. In natural chronological aging, Vata dosha typically increases, which is associated with dryness, degeneration, and reduction in the body tissue. You know, Kapha and Vata are opposite to each other. However, during old age, there can be an imbalance of Kapha dosha, which can lead to fat accumulation, especially when metabolic process Agni slows down and there is a high caloric food intake, lack of physical activity. In the old age, physical activity is reduced and calorie intake is increased. That leads to the accumulation of fat. In allopathy, old age is attributed to slower metabolism, hormonal changes, low estrogen and testosterone, leading to muscle loss and abdominal fat accumulation. Decreased physical activity and loss of muscle mass, sarcopenia, reduces the body's overall caloric burning capacity, which may result in fat accumulation. Why fat accumulation? Muscle loss, decreased physical activity, and overeating. Thus, geriatrics is associated with fat accumulation. It is not considered a disease by itself, but it can be linked to other health issues such as metabolic syndrome, sarcopenia, sarcopenic obesity, increased systemic inflammation, and like high TNF-alpha, IL-6, high CRP, high level of leptin, and low level of adiponectins in serum. Diabetes, heart disease, arthritis, they are the common diseases which take place in the old age people. Mitochondrial dysfunction in muscle cells increases oxidative stress, and increased cortisol level in the older adults, often due to chronic stress, promotes both muscle breakdown and fat accumulation. So this is the chronological aging, and this is the biochemistry behind the chronological aging, and they are some symptoms of what I have mentioned you here, the chronological aging. So how to measure? If you go to the geriatric department, they will first measure your level of activity. The activities of daily living, ADL scale, Kurt's index call, assess the ability to perform basic self-care tasks, bathing, dressing, toileting, transferring, continence, and feeding. These are the 6 tasks for your daily work. Can the patient bath independently, including getting in and out of the tub or the shower? Can the patient choose the appropriate clothes and dress fully without assistance, this is dressing, toileting? Can the patient use the toilet independently, including hygiene and adjusting clothing? Transferring, can the patient move from a bed to the chair and back without assistance? Continence, can the patient control urination and defecation? Feeding, can the patient eat meals independently, including cutting food if needed? So these are the questions which will ask, and this is a score. 1 means yes and 0 means no. 5 is the time consideration. 5 minimum minutes maximum. 5 minutes. 5 this is 2 to 3 minutes. Observe for 24 hours. So in 5 minutes you see whether can he do it, give the answer or not. This is the method of assessing. The activity of daily living, ADL scale, assess the ability to perform basic life care tasks. The administration guideline, conduct the assessment in quiet and comfortable setting. Explain each task clearly and simply to the patient. Allow the patient to perform each activity without assistance. If they need help or cannot complete the task, score it as dependent. No strict time limit, but observe for delay or hesitation. So this is the time consideration for this task. So no score based on the actual performance, not capability. Actual performance, he is capable but not doing, then give a number accordingly. So 6 by 6, fully independent. 4 by 6, moderate dependent, and less than 3, severe dependent. So if a score is less than 3, patient. So now the daily living IADL scale. IADL scale is another scale which evaluates the ability of life independency in the community. And conduct the assessment in a quiet, same thing. There is no strict time limit. Score 4. 8 by 8, fully independent. 5 by 8, moderate independent, and less than 4, severe. So this is the IADL. This is IADL pro forma. Ability to use telephone. This is the shopping ability, food preparation ability, housekeeping ability, and laundry ability. Take description. Can the patient operate a phone, dial number, and talk or message? Can a patient shop for grocery and personal items independently? Can the patient prepare meals without help, including planning, cooking, and serving? Can a patient maintain a clean home, sweeping, dusting, and drying? Can a patient wash and dry clothes without help? These are the tasks, these are the items, and this is the number, score 0 and 1. Time 1 to 2 minutes, where is assess need for assistance, where is assessment, like this. So this is the IADL score, and you can do it. IADL instrument activity for daily living. Next question. In the earlier, I have given you the 5. Next, this is 8 question. Mode of transportation. Can a patient drive, use public transportation, or arrange for rides independently? Responsibility. Can the patient correctly take prescribed medicine? And managing finance. Can a patient manage money, pay bills? And these are the 8 questions in the IADL instrument. Now, next is the cognitive impairment scale. This is also very important. This is the mini mental state examination, MMSE. These are the questions. Orientation. Ask the patient the date, day, month, year, and session. 5 points. Okay. 10 seconds per question you have to give. Ask the patient current location, hospital, home, city, where he is currently present. Name the 3 objects like apple, table, and penny, and ask the patient to repeat them immediately. 3 points. And serial 7, subtract 7 from 100, continuing 5 times, 93, like this, like this, like this. You find whether he can do the attention and calculation. Recall. Ask patient to recall the 3 objects from the registration task. Language. Name 2 objects, pen and watch. Repeat. No, ifs and or buts. Follow a 3-step command. Take their paper, fold it, put it on the floor. Read the following, close your eyes, write a complete. These are the language questions. Visual, visuoceptual, copy 2 circumscription pentagon figures. So these are the assignment. This is called MMSC. Now, Geriatric Depression Scale, GDS, short form, 15 questions, depression in elderly. So, this is the score. So, GDS score, there are 15 questions. Are you basically satisfied with your life? Yes or no? Have you dropped many of your activities and interests? Do you feel that your life is empty? Do you often get bored? Are you hopeful about the future? Are you bothered by thoughts you cannot get out of your head? Do you feel happy most of the time? Do you often feel helpless? Do you perform staying at home rather than going out and doing new things? Do you feel you have more problems with memory than most people? Do you think it is wonderful to be alive? Do you feel pretty worthless the way you are now? Do you feel full of energy? Do you feel that your situation is hopeless? Do you think most people are better off than you? So these are the Geriatric Depression Scale, GDS. 15 questions are there, and they have to say yes or no. Depending on that, you will score and understand the depression scale. Timed up and go, TUG test. This is also very common, given by the geriatric expert. Mobility and fall risk assessment in elderly. Admission. Conduct a test in a well-lit open space with minimal distraction. Use a standard table chair with a seat height of approximately 46 centimeters and arm rest. Mark 3 meter, 10 feet walking distance on the floor using tape or cones. And then ensure the individual is wearing their regular footwear and using any assistive device like cane, walker, if normally required. Provide clear instructions and demonstration before starting. Perform 1 practice trial followed by 1 time trial. Start the stopwatch when the individual begins to arise from the chair and stop when they return to the full seated position. Time measurement, second, and interpretation. If less than 10 seconds, normal mobility. If 10 to 19 seconds, slightly slow but independent. 20 to 29 seconds, difficulty with mobility, needs assistance. Severe mobility impaired means 10 feet walk and sitting and getting up. Three things are being done by the patient. If the person takes more than 12 seconds, they may be at the risk of falling. If the person cannot complete the test safely, they are highly dependent and need full-time support. This is the score. So, vulnerable elderly scale VES 13 for functional decline. Earlier we have found the test, mobility test, whether they are susceptible to fall or not. Now we are doing functional decline. Administration guideline, the survey can be self-administered or interviewer administered in quiet and comfortable setting. Explain that questionnaires help understand their health status and ability to perform daily work. And read each question clearly and allow the person to adequate time to respond. Okay? And if the individual has a cognitive impairment, a caregiver or proxy may assist in answering. The survey does not require physical performance test. It is purely based on self-reported response. Vulnerable elderly survey for functional decline. Age. How old are you? Self-rated health. In general, how would you rate your health? Excellent, very good, good, fair, poor. Functional limitation. Do you have difficulty doing the following activities? Yes or no? Physical function. Can you perform the following tasks without help? Total, sum of the total points. 0 to 13. So, vulnerable elderly survey VES 13 for functional decline. This was also for functional decline. This is also for functional decline. So, physical, now a functional limitation and physical functional questions. Yes or no? Functional limitation, maximum 4 points. Functional, physical function, stopping, crouching and needling, lifting or carrying objects weight 4.5 kg, reaching or extending arms above the shoulder level, writing or handling small objects. Physical functions, this is the functional limitation. We have walking across the room, doing light housework, shopping for groceries, managing money, and bathing and showering. So these are the questions for physical function. This is the limitation, how much you can do. These are the vulnerable level, risk level has been given by the score. So, comprehensive geriatric assessment, CGA pro forma. This is the beginning data we have to fill this form, and then there are different questions for different functions. So, activity, this is the comprehensive assessment pro forma, functional status. So, this is the questions, you have to be independent and need assistance. Activity, phone and everything I have discussed earlier. And now the cognitive function, MMSE score and Montreal Cognitive Assessment score. This is, you can fill it, and this is the comprehensive geriatric, the psychological health, geriatric depression scale I have discussed earlier, and this is the MNA, mini net nutritional assessment, interdependent normal at risk malnutrition. So this is nutrition. So all these questions, mobility and fall risk, and then frailty assessment, and then comorbidity. What are the Clarison comorbidity index? This is a standard protocol, you have to do it. And polypharmacy, how much medicine you are taking, this is also a pro forma, you have to fill it. And social support, comprehensive geriatric assessment for social support, this is a pro forma. And summary, by combining all the parameters together, you make a summary. The key issue identified, further assessment need, yes or no, a referral or specialist, yes or no. So, scoring interpretation and risk level, low risk, moderate and high risk. So, you can calculate based on the summary of all the questions which I have discussed earlier. So, common symptoms of geriatrics versus Alzheimer. This is very important part. Second part, now up to now I have discussed about the geriatric problem. because geriatrics is a common thing which will happen to everybody, whether he is sick or not. But geriatrics itself has some weaknesses, and that has to be addressed by the geriatric department. But your job is to assess the level of geriatric condition and then to refer it to the subject expert. Now I am coming to another important question, because dementia, cognitive imbalance is a part of the geriatric. And if it is progressing very rapidly, and then there is a problem. And in the Alzheimer's disease also, there is dementia. So dementia is common in geriatrics and Alzheimer's disease, both conditions. If both conditions are there, the chances are more. So how to differentiate common symptoms of memory loss, sleep disturbance, pain and depression? They are the four common symptoms which are present in geriatrics, which are present in Alzheimer's. So guideline for palliative care: use memory aids, reassure without correcting harshly, repeat calming, establish bedtime routine, reduce even things stimuli, monitor for night time wandering, use non-verbal pain assessment tools like pain aid, monitor facial expressions for the pain, and for depression, differentiate from apathy, offer structured daytime activities, consider SSRI if necessary. So, may overlap with apathy and confusion in Alzheimer's specific characteristics. They are common due to loneliness and chronic illness. The pain, often reported verbally, often underreported in Alzheimer's disease because his cognitive behavior is very poor, he is not able to report. And sleep disturbance, light sleep, early walking, light sleep and early waking, sleep wake reversal, night wandering and daytime sleeping, and mild short term for forgetfulness, normal aging, and progressive disabling memory loss, especially recent events, is the Alzheimer's. So these are the points are the same, memory loss, but the symptom is different. In common geriatric persons, it is a mild short-term forgetfulness, and here it is a progressive disabling memory loss. So you have to carefully monitor it. So common symptoms in geriatric patient with clear guideline. So constipation, appetite loss, and confusion. Three things will happen both in geriatric patient and Alzheimer's. And the guideline: educate caregiver, ensure hydration, fiber intake, and monitor bowel habits. Offer frequent small meals. Avoid distraction during meals. Observe for swallowing difficulties. Rule out acute causes. Often calm, familiar environment. Use orientation aids. These are the guidelines for palliative care, both either a geriatric patient or an Alzheimer patient. So now Ayurveda has an edge in managing these things. So Ayurvedic interventions in Alzheimer's disease, evidence-based insight. So herbal medicines like ashwagandha, karkumalanga, brahmi, gotokolu, and jyotishmati. These are the medicines. Its preparations have been shown effective in management of Alzheimer's disease. Is evidence-based. So known for enhancing memory and cognitive function. It exhibits antioxidant properties and support neuronal health. Ashwagandha similarly demonstrates neuroprotective properties by promoting neurotic outgrowth. Curcumin is antioxidant, shows inhibits amyloid plaque formation, reduces oxidative stress, and reduces inflammation. Brahmi, traditionally used for cognitive enhancement, studies have shown. This is recognized for neuro regeneration property. So these experimentally have been done, and with the use of the bioinformatics, the mechanism of action of most of these medicinal plants have been published, established, and clinically it is being used for a long time by Ayurvedic doctors. So they can be used. And the Panchakarma therapy is also effective in management of Alzheimer's disease, like the nasal administration of the medicated oil, Shirodhara, continuous dropping of oil on your forehead to make it calm and quiet. Virachan, therapeutic purgation, it detoxifies your body. So Vat and Kapha imbalance which has taken place in aging or in Alzheimer can be controlled by Virachan. And the Basti, medicated, utilizing the balanced Vata dosha. Vata dosha can be balanced only most effectively by giving Basti. Different kind of Basti, medicated enema is recommended, which is often implicated in neurological disorders, potential improving cognitive health. Kapikachu is one of the best medicine which has been used for Parkinson's disease, and this is also good for other neurological diseases. So non-pharmacological interventions like yoga and meditation, and dietary modifications, and lifestyle adjustment, these things are also effective. So I have summarized here herbal medication, number 1, Panchkarma therapies, detoxification of your body, number 2, and non-pharmacological intervention, number 3. So these 3 things can be used as a supportive medicine with conventional medicine recommended by geriatric expert or the medicine person for the aging person or for the Alzheimer's disease. And if these things are combined together, the holistic approach can give better therapeutic impact. So by increasing exercise, if the patient is able to do physical activity, promote them to do exercise, endurance exercise, resistance training, and moderate exercise, different kind of training. This is the published paper, and they have different effects. I'm not going into detail, but it is a proven, evidence-based thing that physical activity of the patient is very important in improving his overall health. So in the Ayurveda, the basic pillars again I will repeat, Ahar, Nidra or Brahmacharya. Brahmacharya means physical activity. Ahar means food should be digestible and should be better absorbed in the intestine. And Nidra, sleep and cognitive behavior. All the 3 things, if are implemented to your patient, the patient quality of life will definitely improve. With this, I come to the end of this talk. The geriatrics and NCDs overlap with each other most of the time. Most of the symptoms are common, but treatment teams are different. The doctors are different, symptoms are common, and patient is also common. And palliative care team should collaborate with subject expert, the geriatric expert, to deliver the best services and achieve the basic goals of palliative care. What is the basic goal? Basic goal is comfort, pain management, sleep, and emotional and spiritual well-being. These are the main functions: physical, emotional, social well-being. With this, I end my talk. Thank you very much.